Can't you hear my heart?
With Valentine's Day approaching, On Call doesn't miss a beat as we consider affairs of the heart, that 7-pound pump that means so much to our physical and emotional lives. The doctors are on call tonight.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
All of them together. And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Blow hard, blow, 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 keep pushing.
And try to position your head.
Pull red handle to open bag.
Up until the time of William Harvey published the De Morto Cordis, or On the Motion of the Heart and Blood, in 1628, it was generally thought that the heart was a producer of heat, and that the lungs and arteries fanned and cooled the heart and blood. They thought there were two systems involved with the blood. One was where the venous blood originated in the liver, and another where the arterial blood flowed from the heart, distributing heat and life to all parts of the body. Harvey's new idea described how blood circulated, starting with the heart pumping oxygen-rich blood out to the body through arteries, through progressively smaller vessels, and then received it back through progressively larger veins. The venous blood would then be pumped by the right side of the heart through the lungs to receive oxygen again, and then back to the left side, ready to go out to the body once again. A revolutionary idea by William Harvey in 1600s. A few had theorized this earlier, starting in Persia and then in Italy, but it was Harvey, following his extensive study of human anatomy, that wrote the convincing argument. Thus, in England, with the support of his College of Physicians, we can say William Harvey began the field of cardiology. Now, cardiology internists provide for the examination and management of circulatory disorders of many types, which occur in as yet unborn babies to the very elderly, including congenital heart leaks and valve abnormalities, holes in the heart, clots and atherosclerosis, dilating and rupturing vessels, hypertension and chest pain, and on and on. We invite you at home to call with your questions concerning heart health. Our phone number is 1-888-376-6225. Again, that phone number is 1-888-376-6225. February is Heart Month, and we celebrate the great advancements science has brought and wrought to the company of cardiology internists like Paul Carpenter, one of the senior members of North Central Heart Institute and the Avera Heart Hospital of South Dakota in Sioux Falls. Welcome, Paul.
Thank you, Rick. It's a pleasure being here.
So you were here a year before, you started a year before I came to South Dakota and have been practicing in Sioux Falls all this time.
Yes.
Yeah, where did you come from?
Went to University of Minnesota Medical School and did my fellowship, internal medicine and fellowship at Abbott Northwestern. And I finished in 1980 and came right here.
And you grew up in a town in Minnesota?
A small town of Grenada near Fairmont, southern Minnesota. So yes, I'm not too far away from home.
Not too far from home. Well, let's talk about some of the changes that's happened. I mean, you think about it, 1980 to 2012, that's 32 years of experience.
Yes.
What's changed?
Well, I think the biggest change has been how we treat heart attacks. Back in 1980, person was having a heart attack, you just watched them have the heart attack. You tried to prevent arrhythmias, control blood pressure. But it was taught that you don't do an angiogram when they're having a heart attack. That was too dangerous. And then fairly soon thereafter, we started intervening. And it's made a tremendous difference because we have people now who have had a very small heart attack where it would have been massive. And I think the other thing, we started angioplasty became first tried in 1977, and that became much more common in the early 80s, and we use now stents, which is the natural progression from the angioplasty.
Yeah, explain that. And angioplasty meaning you've changed it, you've opened it, you've dilated up the artery.
What you do, you have a blockage in an artery, and you pass the catheter down through the blockage, and then you open it up. Like here, one of these arteries here has a high-grade blockage. We pass a catheter down through that, and then we blow up a balloon and open the artery. And now, and what happened initially was that they just blow up the balloon, call that angioplasty, get out of there, and hope that it heals open. Right.
But we found that there was a percentage of people who would go on to close again, and the stents have changed things.
That is correct. There was probably a 35 to 40% chance that it would re-narrow with just angioplasty. A stent is a little wire mesh that is open, and it doesn't. It keeps the artery open, and the percent of re-narrowing then is significantly lower with the stent.
And they also have advanced the stents such that now they, in some stents, in certain types, they'll put a drug-eluting a particular coating on the stents. What would tell us a little bit about that?
The drug-eluting stents even inhibit the artery from healing over the stent. Sometimes the bare metal stents will still heal, or will still overheal and narrow. With the drug-eluting, it limits the healing the body does and prevents the re-narrowing. We use this particularly when there are small arteries. It doesn't take a whole lot of overhealing on small arteries
to plug it up.
But
the problem with the drug-eluting is that there's sometimes it can continue an ulcer and there's inflammatory response, right? I mean, there's some disadvantages.
Right. Primarily you have to use a platelet inhibitor for at least a year, and then even later than that, occasionally it can clot because there's some of that bare metal open to the circulation system and the coagulation system.
Right. And it isn't just the coronary arteries we're doing these dilations and stenting right now. That's another whole world of what's happened new. Tell us a little bit about that.
That is correct. We can do stenting in the carotids rather than having the surgery there. We do a lot of that in the abdomen, in the aorta, in the arteries to the legs. And it can be done for renal arteries.
Kidney arteries?
Kidneys, yes.
So, I mean, when blood vessels are starting to close off, we can go in there, we can open them up and keep the progress of a clotting process or a ischemic process is what we would say in medicine.
Right. And what this has done is prevented the need to have as many surgeries. You can do it non-invasively. A person isn't in the hospital as long, and it's very successful.
We have a question from Tyler. Diagnosed with cardiomyopathy, had flu last winter, virus-attacked heart, blood doesn't pump as it should, short of breath, taking meds twice a day, shortness of breath has improved. Will heart ever get better? That brings us, we've been talking about vascular disease, and we need to come back to the vascular process, but there's another whole area of medicine, of cardiology, about the cardiomyopathies, the weakness of the heart, and a viral-induced heart weakness. Tell us a bit more about that.
Well, viruses, there are certain kind of viruses, the Coxsackie, the echoviruses, can affect the heart, attack the heart. And you can go from a perfectly healthy individual to one that has a very weak heart. Had a patient who had been very active. He's a paramedic. 1 week and the next week he could barely walk across the room. And his heart functioned. Normally the heart ejects about 60% of blood with each beat, And sometimes we're left with 10 to 15%. And with that, there's hardly any reserve. And any little exertion, and the person is very short of breath.
So you want to have that 50-60% squeeze to be able to go out and go for a run or play a game of golf or tennis or be active. Young person gets taken down like that, it's amazing. I've seen people die from a simple virus. Now you described 2 viruses. These are generally diarrhea viruses, aren't they? Echo virus and Coxsackie, oftentimes a diarrhea illness.
They're fairly common, but it seems like more in this time of the year, maybe when there's more colds and flus. It's in my practice, there are times that we've seen 2 or 3 of these in several month period of time, and then can go for several years without seeing any.
Now her question was, is it going to go away? You know, is it going to come back? Is her heart going to recover? And my personal experience has been that sometimes it really does. It just the heart comes back over a 6-month period of time, recovers completely, and you have an almost normal scenario. But that's not always the case.
That's true, and it's hard to predict. There are some that we've seen come back essentially to normal. There are some that will, with treatment, we can usually get it better, but it may not come back.
With medicines?
Yes.
And that's a fine story. We need to talk about the balance of how to treat cardiomyopathy and heart failure. But we'll do that in a bit. Heart ailments are life-changing events. Not only is there the potential for death, but short of that, there may be physical injury that limits activities. And there is the emotional impact when you are presented with your own mortality.
I woke up about 2:30 in the morning with some discomfort in the left side of my chest, and it really didn't hurt that bad, but it was something that I'd never experienced before. So I woke up my wife and had her take me up to the emergency room at the Brookings Hospital, where they hooked me up to a bunch of machines and my heart stopped. I didn't know much about the heart at the time and really thought I was wasting my time going up, but it was just an unusual feeling. Not really a lot of pain associated with it. Don't really know why I went up. Maybe just by the grace of God I decided to go up to the hospital. You always see the defibrillators, you know, hanging on the walls and stuff, and I've just never given it much thought. Since then, I saw, actually it was on TV the other night, they said the survival rate when this happens is usually 5%. So I figured the only reason I survived is I was in the emergency room. I remember waking up and they just said, we're going to send you down to the heart hospital. And I went down there, and by probably 10 o'clock that morning, they had done, I think they call it a cath. The recovery, probably the first 2 or 3 weeks, I had a lot of soreness, I would guess, from they did CPR and the defibrillation, or whatever you'd call it. That probably was the most discomfort. When there's an electrical problem, their recommendation just, they don't know if I'm going to have this problem again, but their recommendation is to put a defibrillator in so that if you do have the problem again, obviously if you're not in the emergency room and there's nobody around to give you a CPR, you're probably going to die.
Great story, Tom. Thank you so much for that. He said that he was not in extreme discomfort during, or having a lot of pain, but that it was this feeling that there was something happening when he woke up that was so important to get him there, so that he was there to have that resuscitation, and where they pumped on his chest and brought him back. I mean, kept him alive. I mean, life-saving scenario. So how often do you think that sixth sense feeling is?
Well, I think it's quite often. Of quite a few of my patients have described that there's something going on in the chest, and yet it wasn't pain. It was just a kind of a funny feeling. Sometimes it's if I could just belch, if I could just get rid of that bubble that's there. And that may be the early warning that this is a heart attack happening.
You know, as somebody said, what about a silent heart attack? We just got a question on that. There are people who have this type of a thing, but no symptoms. And then there are people who feel like the elephant is stepping on the chest and crushing them, and they're dying, and they know something very bad is happening. It's just every part of the rainbow there. Why would that be so different in people?
I don't have a good answer for that.
Come on, Paul.
And I think that, you know, it's not just on the chest. We've had people come in with a bad toothache with their lower jaw, or I get tight in my throat, or we had someone come in with just pain in their elbows. You know, there was one lady I saw in the emergency room that had right upper quadrant pain. We thought it was a gallbladder, and it turned out to be heart. So I think if there's a pain that's hanging on there and you're uncomfortable with, especially if you're starting to sweat a little bit, you need to go in and be seen.
Okay, so sweat, I mean, you know, of course, the emergency room is going to fill up because there's a million people who have pain. But one clue I have is that if it's with a deep breath or when you're moving your shoulders around, that's oftentimes either lung or it's muscles and bones, or if it's made worse with eating, it's esophagus, and you can take those clues and say, okay, well, we can work on those. But if you're feeling some kind of unease, I think it's an appropriate thing to come to the emergency room.
I agree. If the pain is worse with taking a deep breath, it's likely not cardiac. You know, maybe some other thing that could be serious, but it's not cardiac usually.
Yep. So I'll give you a great story. Here's a case. She's in her 80s. She was admitted with a heart attack. Her cardiac enzyme troponin went up just a little. I came in to see her. She's my patient, so the next morning I come by. The guy who admitted her, two guys admitted her, crackerjack docs, found the MI. That's it. I came in and I examined her, and I said, take a deep breath. And did that hurt you a little bit? Yeah. It was a blood clot to her lung. That's what it was. And so, you know, the issue is, it's hard to know sometimes what these things are.
That's right.
It is. Any take bottom line?
If it's really bothering you, if it's pressure or tightness that doesn't go away, it's far safer to go in than to stay at home.
Yeah. And if you get this pressure that's kind of a crushing tightness that happens when you exert yourself, goes away with rest, you need to bring that to the attention of your physicians.
I very much agree.
All right. Well, let's talk a little bit more about medicated and non-medicated stents. We did address that a little bit. Do you want to say anything more? Why would, you know, the medicated, maybe the smaller stents,
yes,
not necessarily the larger stents.
The larger it is, the less the need for a medicated stent. The problem with the medicated stent is that you're on Plavix or Effient, one of these other clot or the platelet inhibitors, and you have to be on that for a year. And if you develop an ulcer, you need to have knee surgery or something, that has to be postponed during that length of time.
Okay.
Or, you know, if you would have a bleed in the head, it gets to be a real problem during that time.
While you're on these blood thinners. Just bought blood pressure tester. I've been testing myself for 2 weeks, irregular heartbeat. Is that a symbol of something bad happening? Could this be serious?
Some irregularity of the heart rhythm, we all have some skip beats. So it all depends on how much. If it's irregularly irregular most of the time, then you need to be checked because it could be atrial fibrillation. And that is a rhythm that we have to really look at carefully because there's a risk of stroke associated with atrial fibrillation.
Well, and but I remember the studies of the med students. They were first discovering how to do a Holter monitor. I mean, I learned this in the late 70s. And they found that, their guinea pigs had huge numbers of dysrhythmias, you know, abnormal rhythms. And so that the normal is quite abnormal. What really is if a person is having a very irregular rhythm and it correlates with an abnormal rhythm on the Holter.
That's right.
Any other comment about Holters?
No, I think if you're having a lot of irregularities, maybe you should go in and have an EKG or have a monitor done to see if it is just the usual kind of frequent non-worrisome rhythms, or if it is the atrial fibrillation.
Yep. We asked about silent heart attacks. Explain what congestive heart failure is. We did talk about heart failure just a little bit. I'd love to get into this a little bit more. There's a lot of people who have it.
Congestive heart failure is when the heart is not working well as a pump. And what happens is the blood backs up into the lungs. And I like to describe it as when you're short of breath, because normally you have the oxygen, you're getting air through through the bronchioles, and then you're having the arteries going right next to it, and the blood goes back and forth. The carbon dioxide and the oxygen go across that thin membrane. When you have heart failure, you have extra fluid in the lungs, and you have to go through a layer of fluid, and that's where you become very short of breath. So with heart failure, what we have to do is get rid of that extra fluid, strengthen the heart's contractility.
And how do you do that?
We do that with some diuretics, water pills, to get rid of that extra fluid. We do that with some of our medications that help to strengthen the heart function. If someone has a very fast heart rate, you slow it down. Sometimes if they go too slow, you need a pacemaker to raise the heart rate faster.
Now, there's been a lot of changes with medicines to improve the squeeze of the heart. I mean, diuretics have been for a long time, but the inotropes, or maybe even the vasodilators, have been very successful in the 30 years you and I have been practicing. I mean, I remember when the ACE inhibitors first came out, it was a huge difference in being able to take care of people with heart failure. What would you say are the three most important heart failure meds aside from the diuretics?
I think there's the beta blockers, the carvedilol kind of medication, and that it was initially beta blockers we wouldn't give because
don't give the beta blockers. I mean, you know,
it makes the heart function worse. But it was found as you control the heart rate, and especially with carvedilol has a bit of a vasodilator component to it, down the road your heart function improves. The other thing is the ACE inhibitors, which or the ARB, are agents that are blood pressure meds. They're vasodilators, and it allows the heart to pump against less resistance. If someone has heart failure, what we like to do is have their blood pressure on the low side, maybe 100 to 110 or so, rather than 140. And by doing that, the heart is able to function and pump more efficiently. As far as you asked for a third?
Yeah, I was thinking of ARBs and ACE inhibitors and the beta blockers, but there are other inotropes, but they're not nearly as important as, I mean, there's the adrenaline-like drugs, but actually the beta blockers work because they block the adrenaline.
Correct.
So it's just borrowing a little bit more when you get to these more expensive options.
Correct.
Let's talk about the worst heart failure, a person who can no longer sustain their life with their heart, and the option is a heart transplant, but you can't get the transplant, so now they're starting to use ventricular assist devices. What's your take on those?
I just had a patient that we had sent to the Mayo Clinic who was just failing. We had tried everything. We had her on all the medications, and she kept coming in the hospital more and more short of breath. We ended up sending her to Mayo, and she's now on one of these LVADs. She's on an assist device. It's interesting, when you listen to her, there's a hum.
There's no love dub. It's a hum, isn't it?
It's a hum. And she's doing well. She would not be around today if it were not for that device.
And most of the people who are on LVADs are there as a transition until the heart transplant.
Correct.
Right. We're seeing those little red cases hanging on the walls in the public buildings and businesses we visit. We may know what they are, but there may be an intimidation to actually using one. We visited with the emergency staff at the Brookings system to demystify these red, ubiquitous AEDs.
What we have here is a couple of AEDs, and AED stands for either automatic or advisory external defibrillator. This machine is something that is a good example of what you may find hanging on a wall. This happens to be probably the next generation AED for first responders, some healthcare providers. In general, there are 4 steps to any AED. That is going to be power, putting patches on, analyzing the rhythm, and the shock. Part of the beauty of an AED is that once you turn it on, it starts telling me what to do, so I don't even really need to know what's going on with the AED, exactly how to use it, as long as I'm brave enough to take it off the wall and turn it on, put the patches on. I'm doing the best thing that I can for the patient. Often the case has an alarm on the door, and that's intentional. Shouldn't be afraid of the alarm. It's a good thing. It's calling for help. Let's just say that we're at Hy-Vee. We're walking down the produce aisle, and we see someone in front of us maybe suddenly collapse and go to the floor, and we go over to them and say, "Hey, are you okay?" You know, and there's no response. And so at that point, we're just kind of visualizing. If you're comfortable with taking a pulse, fine, but otherwise, you know, just looking at the patient, are they breathing? Do they look like they're alive or not? And if you feel like they may have gone down having a heart attack, a cardiac arrest, then if you're alone and this is an adult, go for an AED. Hopefully there's one hanging. Otherwise, you know, holler for help. Start CPR. Someone will bring the AED. If the person has clothing with a zipper like this, great, just unzip it. Otherwise, don't be afraid just to rip buttons open, get at the chest as quickly as possible. So again, the patches themselves have pictures on where they go on the patient. So it's fairly foolproof. So all I have to do is peel the backing from it and they will stick. So this one goes right up here, push it down, take the backing off of the other one, goes right here. So with the machine then being on, and this would be plugged in.
Stand clear.
Here.
Analyzing now. Stand clear.
The machine is analyzing.
Start CPR. If you witnessed the arrest, push cancel. Stand clear. Push shock button.
You see that the shock button is flashing. We're going to push it. Don't touch the patient. And it just shocked. And at that point, you shouldn't be surprised to see the patient jerk from the shock. So if I just follow the directions of the machine, I'll be doing the correct thing. I don't need to know anything about rhythms. All I need to know is that this person looked like they needed help. I knew where there was an AED. I pulled it off the wall, hooked it up, followed the directions, and it was just really that simple. We should all feel comfortable enough to use this equipment, even if we're not positive what's going on with the patient. So if we hook this patient up and they're not in one of those rhythms that's shockable, the machine isn't going to shock. So it is impossible to hurt anyone with this equipment.
Boy, that's quite good. I mean, let me ask you, have you seen this make a difference?
Oh, yes. When you go into a ventricular tachycardia, ventricular fibrillation rhythm, you only have about 10 minutes before you have irreversible damage done to the brain. So any way of getting them back into regular rhythm makes a huge difference. There's lives that have clearly been saved because of this.
And the AED device is part of that?
Very much so, yes.
I remember realizing how important the shock was compared to this resuscitation effort in a patient that was having a cardiac arrest. And oop, there he goes. Oh, I'm looking at his monitor. Oh, he's in a VFib. We know that he needs a shock. Bang! And he was still awake, and he shouted at me, and then he was back with us. Mm-hmm. Whereas if you pump on them for 3, 4, 5, 6, 7 minutes, you're losing ground, and then the shock happens, but then they're completely out of it, and then it's a while before they get back.
Right.
Now, there's been a new thing about the value of breathing for people or not. The emphasis is on the pushing of the chest and not the intubating. Do you know anything about that new trend?
I certainly read that this is the route to go, especially if you have an AED that you can that you're getting and hooking up, where you can go ahead and get them converted right away. So I think it's concentrating on the conversion. CPR
and then the conversion.
And then the conversion.
As fast as you can. Actually, if you don't breathe for them, I've heard this, that their blood gets acidotic, and it's a better position to be acidotic for recovery and eventual return to function.
Yes. And one other thing that we could go from here is the cooling protocol that we have started doing.
Oh yeah, tell us about that.
We have found that people that have had an out-of-hospital arrest where they've had CPR, maybe the AED, and they come in and they're unconscious, you don't know whether there's been irreversible head damage done. And so if you cool the body for 24 hours, there's a better chance that they're going to wake up without having the brain damage. For some reason, you're protecting the brain cells. Certainly, I've seen it work in some of the patients that I've had. I thought their CPR had gone on too long to have caused permanent damage, and indeed, they come back and they're wide awake and go back to work. And
how do they cool them? I mean, do you get into you take their blood and recirculate it through a cooling system, or do you?
Well, cooling blankets, ice. It's, and you sedate them. You really sedate them so they're not fighting against the system, but you cool it down, and it does make a difference.
For recovery.
For recovery.
You give it for a 24-hour period of time.
For 24 hours, and you start rewarming them slowly.
Whew. Well, we've got a bunch of questions we should jump in. A woman from Sioux Falls, 72 years of age, blood pressure goes as 85/55 several times during the day, otherwise it's 116/60. Is this anything to worry about?
If the blood pressure is that low, the key part is she dizzy? If you're not dizzy, there's not a problem with that. It's actually better the lower blood pressure you have. It's just when you're too low and you stand up too quickly, often people get a little dizzy. Then that can be an issue.
As long as she's not falling, and she's not getting dizzy when she stands up, I think that's an important one. From Aberdeen, how much information can be obtained from an EKG? How much data do we get from an EKG?
Well, we get some. It's not a completely diagnostic test, but we can tell about your rhythm, whether there is some acute changes of a heart attack. We can get a good idea whether you've had a heart attack. We can see heart block. Do you need a pacemaker? We get a fair amount from an EKG.
Yeah, and that new heart attack, when there's changes that are happening over the next, the first 10 minutes, you see a heart attack happening. That can certainly tell you a lot. Well, there's a whole field of medicine that's built around that EKG, but it's probably not as important as we used to think it is.
I think with all of our other tests, yes, it's not as important, but it's still a very important part as far as if we're deciding if they're having acute heart attack or not. The EKG is very important.
How about the difference between a Holter monitor and a vent monitor? That's an EKG of a sort. Can you explain that, Paul?
Holter monitor, you're watching every beat during a 24 or 48-hour period. An event monitor is something that you wear for a month, and that's for people that have arrhythmias that are intermittent. Maybe they only get them once every 2 weeks or once a month. You're likely going to miss it on a Holter monitor, but with an event monitor you can pick it up where they will push the button when they're having symptoms, and we can see exactly what it is that's going on.
I was talking with somebody today in my office, and they said that they had a friend who had passed out the passing out episode that's called syncope that doctors call. And there might have been seizure-like activities. Well, gee, is it a seizure? Was it a heart rhythm abnormality? That's a very serious deal that should not be left alone. That needs a direct attention for evaluation for either seizure or an event.
I agree. And often we have the neurologist and the cardiologist kind of looking at one another saying, is it our area or is it yours?
And often it's the cardiologist saying it's a neurologist's problem, and the neurologist says it's the cardiologist.
That is true.
We have a call from D. Smet, a male, recent sleep study, sleep apnea. Is there a connection between heart attacks and sleep apnea?
Well, there is. Sleep apnea, your oxygen saturation is going down because you're blocking your airway when you're sleeping at night. And anything that your body's responding to that by trying to pump faster and harder. So there's a greater incidence of heart attacks in people having sleep apnea. Sleep apnea really needs to be treated if you have underlying coronary disease.
If you can treat it. The problem is it's not always that easy.
That is true.
I have one gentleman who's been able to find a device that he can position his mouth. It positions his mouth, and that does a trick. Some people are successful with the nasal things, but the different CPAP machine masks are very important.
There's a high percentage, or quite a high percentage of people that cannot tolerate that. But I think there are other methods, like you say, the mouthpiece.
And sometimes surgery. There's a surgical procedure. But it's so important, I think, if you think about it, a third of your day, which is while you're sleeping, where you're oxygen depriving your heart and your body, you're actually causing early aging, or premature aging. Alzheimer's disease is on the way. And it's an important problem with the epidemic of obesity in particular.
You know, it's a real problem when the spouse says, I sometimes sleep in the other room.
Yeah, you know there's a problem then. So, important message. If the obesity, hypertension, snoring, you hear your husband or wife not breathe for a period of time, a apneic episode that you observed.
That's right.
Sioux Falls male, 73, had a vascular test, says no cholesterol in veins, but doc says could have soft cholesterol. What's soft cholesterol?
In the lining of the coronary arteries, you can have some plaque that is soft. It's not calcified. And so when we do a balloon on it, it would just squish, whereas some of the harder ones will pop as you open them up.
Really? You can feel them pop.
You can see the pop, actually.
Yeah.
The soft ones are probably as dangerous or more dangerous. We think you have a plaque here, and there's that lining over that plaque. If that gets disrupted, that's where you have the clot form and where you have the heart attack. And it's as often in, or maybe more often in soft plaques than it is with the hard ones.
You know, we used to have atypical angina. That was a big thing in the 80s. Remember that when, oh my gosh, Prince metal angina. People did not have plaques, didn't have artery disease, but they were having spasms. And then it was being promoted by the companies who were selling the calcium channel blocker drugs that we need to use that drug all the time. Of course, we found that didn't work. But there is heart attacks that occur purely because of clot forms, not because there's a fixed plaque or that there's an obstruction. Just a clot occurs.
Yes.
What's your take on that? What percentage of people who have heart attacks have a clot heart attack?
Well, I think there's a clot in majority of the heart attacks. It may happen on top of a blockage that was there of 70%, but it could happen when their blockage is only 30%. There's something that disrupts that clot or that lining over the plaque, and then clot forms. And this is where, let me talk a little anti-smoking. We know that cigarette smoke makes platelets much more sticky. And so people that are smokers and have a heart attack have a greater risk of dying before they get to the hospital because they have a greater clot burden.
Yeah, and sleep apneic patients too, because of that hypoxia.
Right.
Well, and in cases where you have known coronary disease or high risk for coronary disease, that's where a baby aspirin a day makes a difference.
It does. And it's usually tolerated very well. There's occasional persons that are allergic to aspirin or have a very sensitive stomach or bleed easily, but majority of people can tolerate the baby aspirin.
Yeah, and my sense is it's 81 milligrams best for colon polyp prevention, which isn't your territory, and they don't know the right dose for clot prevention, 81 to 325. Not more than 325, but 325 down. Am I on target with that?
Yes, very much so.
All right. Well, clogged arteries and misguided nerve action are not the only things that can adversely affect our hearts. Our mental states, our moods and stresses levels, as well as our emotional ties to family and friends can support a healthy heart or cause a broken heart.
Your emotional health, your mental health can very directly affect your physical health. I'll give you an example. Sometimes people come to me and they say, I've been having these attacks where my heart starts to race, I start to sweat, I start to breathe really heavily, I start to have this overwhelming sense of fear, and immediately I know that that's a panic attack or an anxiety attack. And usually the reason that people have those sorts of attacks is because they're feeling an immense amount of stress in their lives, or they're feeling very, very overwhelmed about emotional things that are going on. And so one of the things I try to do is simply get them to open up and express their feelings. They talk about their stressors, talk about why they're feeling so overwhelmed in life, and a lot of times that can help them avoid these panic attacks. People can suddenly have a panic attack and not know what it is, and that is often quite scary for people. I've known clients that have mistaken a panic attack for a heart attack because there are a lot of the similar symptoms: heart racing, sweating, overwhelming sense of fear, and they think they're dying. And they've actually called 911. I've had people call 911 saying, hey, I'm having a heart attack, can you come pick me up? And the paramedics get there, and it's not that. And so that's when I get the call about a week later saying, hey, this person has some severe anxiety, can you help out? The body, when it gets stressed or gets overwhelmed, sometimes those sorts of mechanisms can get overused or sort of out of sync, and so the body will pump, epinephrine or adrenaline into our systems when it's not really needed, and that can induce the panic attack. Depression, which is one of the major mental health issues in this country, people with depression can get all sorts of body ailments: back pain, headaches, sciatica, stomach problems, intestinal problems. And a lot of those symptoms are what we would call psychosomatic, so they're more or less in your head. It's not to say there's not some physical ailment that's actually happening, but a lot of times it's exacerbated by the fact that you feel so down or you feel depressed. There tends to be a little bit of a stigma, I think, today in that people don't want to admit or talk about the fact that they might have depression or anxiety or some other mental health issue, because I think it's viewed as a weakness. I guess what I say to people on that front is, let's pretend you had some sort of a heart condition and you needed help. Would you go to the doctor? And most people say, well, yes, I would. And I say, well, it's sort of the same thing when it comes to mental health issues. Oftentimes there's a little bit of a chemical imbalance that can create a mental health issue. Would you seek help for that? Well, yes. And so lots of times that helps to ease people's fears about seeking mental health help. There's tons of research out there that says that if you have good social relationships, good friendships, a good family life, that can decrease a lot of stress, anxiety, can decrease the symptoms of depression. And so it's really worthwhile to try and improve those relationships in your life. And what I would say to people is there is help. You just have to go and seek for that help. I think people get so depressed sometimes that they're afraid to even ask for help.
Well, do you have clues that you see in patients that might be stressed that could be bringing on stress-induced heart disease? I mean, tell us about stress-induced heart disease in your mind.
Well, stress causes an increased heart rate, increased blood pressure. If you have underlying coronary disease, you can have angina as well with stressful situations as you can with physical exertion. There's one illness, though, that is clearly related to stress. It's called Takotsubo disease, or it's actually a Japanese term for an octopus trap. It's where the heart at the apex doesn't move, but just the proximal part moves. It's so
the point of the heart is dilated.
It's dilated. And this is a situation that happens under severe stress, where people have lost a parent or a child, or been in a particular stressful situation, such as a holdup or any kind of a situation where there's extreme anxiety. You can start having symptoms like a heart attack. And we'll often have EKG changes of a heart attack. We'll have slight enzyme rise. Well, when you do an angiogram, the coronary arteries are normal. And you see this big dilated tip of the heart right here.
So this is the part right up in here. It's dilated.
It's dilated and contracts poorly. But what happens is within a month's time, within a couple weeks, that'll come back to normal. And it's all pointed to that there was a whole lot of sympathetic, a whole lot of adrenaline released, and it somehow affected the heart, and it heals. There's really little permanent damage, but can be serious at the time because this is an irritable heart right at that time.
Okay. So, in other words, this point of the heart dilates out right in here. All right.
It's also called broken heart syndrome.
The broken heart syndrome. Well, I mean, you're making a point that the emotion isn't one side of us, and our physical body is the other. It is all together. And I don't know how your experience has been, but when I see a older couple split by one dying, it's often the case that the other one will die right afterwards, or that they go through a tremendous stress.
Correct. Well, one of the things I have heard that if you have a pet at home, that actually helps survive, because there's something else, someone else to deal with, someone else to
give
the attention to you. Yes, but I've certainly seen that, and it's fairly frequent.
Me too. I like the idea of the pet. We have a great dog. You know, we've had several dogs, but this dog right now that is just such a happy, friendly dog, and it just makes my heart warm. My heart warm to think of her. A woman from Sioux Falls, 65-year-old, has old man, has atrial fib, shortness of breath. What could cause this, and how do you treat it? So this person's husband or father apparently has atrial fib. Let's talk about atrial fib for just a minute. We don't have much time. Quickly, what could cause it, and how do we fix it?
Can I tell you what? Normally the atrium contracts, then the ventricle contracts. With atrial fib, each little fiber in the atrium is trying to contract, and so it isn't coordinated, and it goes fast. What can cause it? Long-standing high blood pressure, valvular heart disease. What you have to do is slow the heart rate down. You have to put people on anticoagulants, because there's this risk of risk of strokes.
Slow them down, put them on warfarin, and that's most of it, isn't it?
That's most of it.
Quickly, mitral valve prolapse. What is that?
Normally the mitral valve closes like this. Sometimes one leaflet drops behind and it leaks. That's called mitral valve prolapse.
And that is dangerous or not dangerous?
It depends on the degree of leaking. If it's very mild, it's really not dangerous. Sometimes it can be associated with some rhythm problems, but it's the degree of leaking that really is the key part there.
Person has severe headaches, takes a beta blocker, takes lisinopril, takes simvastatin, can't get rid of the headaches. Any clues?
A lot depends on how high the blood pressure is. You need to control the blood pressure. You have to look and see if they're reacting to one of the medications.
Simvastatin, I've seen people have problems. Have you seen people have memory problems? I had a patient who had, I'm thinking, pretty close, a memory problem related to simvastatin. Have you seen that?
Not that I've recognized, but certainly can be.
It sure can be. Cardiac patient on blood thinners concerned with side effects of taking aspirin at the same time as warfarin.
We have a lot of our patients on both, but you have to be careful. If there's bleeding, then you need to stop it. But the aspirin protective effect on coronary disease, that's why we often have people on it.
We have them on both sometimes, don't we?
Yes.
Earlier, we heard from Tom Bozied, a heart patient who survived a very dangerous event just a few weeks ago. Many years ago, I was called upon to assist another member of his family, his father. It was just turning 1982, and I was a new physician in town celebrating the changing of the year with friends when the emergency room called. Someone was having a heart attack. That means a blockage was happening in a coronary artery that feeds the muscle of the heart. The EKG showed injury was occurring across the front part of the left ventricle, which is to say that it was a big one, with a significant chance of death, or at least the consequence of a profound weakening of the heart, and with resulting weakness and disability if the gentleman even survived. What was worse, in my patient, the pain would not let up, which meant the destruction was extending and spreading to more and more heart muscle. It was the dawning of a new age of treatment for coronary artery blockage. The Portuguese first put X-ray dye into arm vessels in 1927. The Germans did so into the center of the heart in 1929, and crudely into the area of the coronary arteries in 1953. But it was in the 60s that a pediatric cardiologist at the Cleveland Clinic began running, or as they call it, snaking, skinny plastic tubes from the groin up around the aortic arch. Then, after injecting X-ray dye, the coronary arteries were visualized under fluoroscopy. They called it an angiogram, coming from Greek words angion, meaning vessel, and gramma, meaning to write or show. In later years, they began exploring ways to try and open arteries and improve blood flow to save heart muscle before and during heart attacks. In the weeks before that fateful night, I read an article in the New England Journal of Medicine how researchers were able to inject clot busters into closed-off coronary arteries, and if done soon enough before complete damage had occurred, then lives could be saved. That was New Year's Eve. I called Sioux Falls, found a cardiologist who had just learned to do such a procedure, and we sent the patient down. The story goes that the patient was treated successfully and lived many years longer, finally dying of something entirely different than heart disease. It was a new era, and everything about caring for people with heart attacks changed after that. So, any take-home message on that, Dr. Carpenter?
I think if you're having pain that is worrisome for a heart attack, you go in right away. And I think you should also make sure you deal with blood pressure, watch smoking, and exercise. You do those sort of things, we can reduce the risk of having heart disease yourself.
We do. I like to put my word in. I know that they talked about obesity in recent articles, and found that an obese person who's in good shape has as good a chance of living a long, healthy life as a thin person who's in shape. It's the shape, it's the activity, it's the physical activity that seems to be most important.
That is very true.
Any particular issues about the coronary artery that we'd like to finish off with?
It's just getting in early. Once a person starts having a heart attack, if we can get that artery open, we can save a lot of heart muscle. So we had a guy that came in just last week, 12 hours of pain. We couldn't do anything about that. But if you can get in within an hour or two, less than that, we send people out that have nearly normal heart function.
Didn't lose heart muscle. Still able to squeeze 50 to
Correct.
60% of the ejection out there. And that's the clue. You've got to get in. If you're getting that chest, now let's just say it again. What kind of pain to clue you in that there might be heart disease?
It's often a pressure or tightness, not really a severe pain, but a pressure or tightness discomfort that just doesn't go away, or especially if you've had it when you were exercising. That's part of the advantage of exercise, If you say, well, I'm having some discomfort now that I didn't have last week when I did the same exercise, you should be coming in.
You have an idea then. Well, that closes the book for our show this evening. Affairs of the heart are never simple, whether physical or emotional. I sincerely thank my studio guest, Dr. Paul Carpenter, a cardiologist, internist, and one of the senior members of North Central Heart Institute and the Avera Heart Hospital of Sioux Falls in Sioux Falls, South Dakota. Thank you so much, Paul, for joining us.
Thank you, Rick.
Great. And thank you, our viewers, for watching and calling. Your questions and input do make a difference. Until next time, have a wonderful Valentine's Day. Do something nice for the ones you love, and stay healthy out there, people.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.